Clay, you okay if we go ahead and get started? Well, we'll let, I know that there'll probably be some people calling in late, but I think that's okay.
Yes, jump right in.
Okay. Well, hi, everyone. Welcome again to our quarterly Diabetes Management Clinical Community of Interest call. This is Miley Javlinsky from CMI, and just a reminder that we will be recording today's webinar for those who aren't able to call in, and would just ask that if you are not speaking, if you could put yourself on mute to minimize background noise. Today, we're going to be hearing from Dr. Mishra from KP Colorado, who will be discussing the delirium work going on in the Colorado region. And in a little bit, Dr. Clay Angel will provide a more of an introduction. But I just want to say I think we're really excited to have this conversation and learn about KP Colorado because as many of you know, we don't have our own KP hospitals in Colorado and instead work with contract hospitals. So it's going to be really great to get the perspective about what works around delirium management when you're working with hospitals that are not owned by KP. So we'll be hearing from Dr. Mishra, and then we'll have plenty of time for discussion. And as we get started, just a reminder about this community. So we've been meeting for a couple years now with the objective to raise awareness around delirium and effective prevention management practices, to share tools, and also, I think, really to make connections across regions. And as you can see, we always put in here the folks that we have as part of the community. We've got people from an array of backgrounds and roles. And, of course, if there's anyone that you would recommend be included on the distro list, please feel free to send my way or to Clay's way. I'm going to turn it over to Clay to add his thoughts, and also I'm going to now kind of pass the ball as well.
Great, thanks, Miley. So this is a really interesting topic today. Raj and I have been talking over the past couple of years since his joining Colorado, I think 3 years ago. And as a hospitalist, both of us are hospitalists. We've had good conversations, and I've been really impressed on the rollout of the delirium initiatives in Colorado. So I think these calls, as Miley said, are really good ways to connect each other, learn best practices, and then figure out what different colleagues are doing in different regions that have their own unique challenges. So I won't spend too much more time on intro. We like to save time for questions, but I just wanted to kind of give Tracy a heads up, because Tracy, I see you're on the call as well. As we go through this, feel free to jump in. I know you've been involved in this work from the beginning as well, and I don't know if Jan or Wendy are on Dan or Wendy are on the call, but anyone from Colorado, feel free to interject and jump in. But Raj has done some great work, and Miley and I will kind of just add in our thoughts as we go along here too. So thank you all, and with that, Dr. Mishra, welcome, and thank you for your time.
And we can see your slides, and we can see your slides too. So looking good.
Oh, great! Thanks. So happy I didn't forget how to do that. Thanks for the introduction, both Clay and Miley. Hello, everybody. Can you hear me okay?
Yes.
Can you hear me okay? Okay. So welcome to today's webinar, and thanks for having me here. My name is Raghav, and today I'll be sharing some of my experiences of working on this delirium project for Kaiser Permanente in a non-Kaiser hospital setting. So I've been a Kaiser hospitalist since 2014, and a year after joining Kaiser, I started work on this project as a physician champion at SCL Good Samaritan Hospital, which is in Lafayette, Colorado. So a little bit of a background about Good Samaritan Hospital and its parent organization. SCL Health is a nonprofit organization which operates about 9 hospitals in 3 states, Colorado, Kansas, and Montana. And Good Samaritan is one of those. It's located 10 miles from Boulder downtown with this beautiful view of the Front Range from our telemetry and surgical floors, which face westward. So I'm not trying to sell you Colorado, but it's gorgeous out here. So Good Samaritan is a community-based 250-bed acute care hospital and our emergency room gets about 45,000 visits annually, and roughly a third of them get admitted. These figures are as of 2015, so we had 13,000 admissions for that year for adult medicine. And to give you a sense about the proportions, about 80% of these annual visits and admissions to Good Samaritan are Kaiser patients, and most of these patients that are admitted they're admitted under Kaiser Hospital Medicine, which is the department that I work for, and we have about 25 full-time KP hospitalists and 5 moonlighters, so about 30 people. And there's another hospital medicine group at Good Samaritan, which I believe is about a fifth of our size. So I'd say 35 hospitalists. And with that background, I'll start to talk about the Delirium project. The Delirium project started in 2013 with a goal to prevent, reduce, and effectively treat inpatient delirium. And I believe this was an initiative by the Department of Quality in Kaiser Permanente, and the setting is SCL Good Samaritan Hospital, which is another organization, a partner organization. So again, Kaiser project in an SCL hospital setting, which is the experience that I've been asked to share with this community of interest, how to champion a Kaiser project in a non-Kaiser hospital setting, and how to get engagement and traction towards any KP quality or safety project with a partner organization. Scope of the problem of delirium, when you look at this, you really don't think that anybody who has worked in healthcare needs to be convinced that delirium as a medical condition can and does lead to all of these bad things: hospital-acquired infections, complications, DVTs, readmissions, falls, injuries, financial losses. And in fact, on any given day when I or my partners are rounding in the hospital, anywhere from 60 to 80% of the patients on our list are geriatric, meaning more than 65 years or older. And that population, which is predisposed to, and that is the population that is predisposed to developing delirium and these complications. And doing the math from the admission numbers that I shared with you initially, this amounts to about 8,000 to 10,000 patients who are annually at risk for developing delirium only at my site. And when I started this project, my boss for the project, Dan Johnson, told me that the project was launched in 2013, and in the last couple of years, there were some factors that had led to physicians not liking the delirium order set, which had already been revised once, and despite that, there was no uptake, and hence they were not using it. So my initial efforts were formally around meeting people who were previously involved in the project to get an understanding of the essentially the organizational history around this project, and to at the same time I wanted to be up to date with the current evidence-based literature on delirium. And my manager for this program, Tammy Kelly, provided me with Sharon Inouye's HELP program, which is HELP is an acronym for Hospital Elder Life Program, and that's a great resource on this topic. So with this, I started out to explore what had gone wrong in the past. And one of the initial exercise was that the strongest evidence that existed in all of the literature on delirium was in favor of implementing non-pharmacological interventions like maintaining day-night cycle, reorienting patients, and all the good stuff, hearing aids, glasses. And as you can see, that was missing from this order set that was in place when I came on. And there are some other things listed, like a back massage and warm milk, which would be nice if that were to be happening, but it was not. And I learned that these non-pharmacological interventions were sitting somewhere in a nursing care plan, and I don't think anybody was looking at them anymore because it was not a part of the natural workflow of nurses to go seek a folder when everything was electronic, everything else was electronic. So another thing that came to my attention when I spoke with people was that there was something in place earlier to the effect of implementing or ordering non-pharmacological interventions, but it was too cumbersome, and it came down to an argument of whose responsibility was it to order the non-pharmacological measures. And maybe it was something like this. The first image that I have on this slide on the top, each individual box probably needed to be clicked by physicians to order the non-pharmacological measures, and that frustrated the providers, and that was taken out of the physician piece and put in the nursing care plan in a folder. So the strongest piece of evidence in managing delirium had fallen through the cracks of the argument about whose responsibility was it and how, or where it should be in the scheme of things in patient care. And the other element that stood out was that physicians wanted to order olanzapine, and it was not listed as one of the medications in the order set. There was only haloperidol and Seroquel. Yet another reason was that physicians wanted to sometimes use the delirium order set, and they forgot to. And I think we've all been there, where we're in the middle of putting some order, and we get paged, or somebody stops to discuss a common patient, and task interruptions like these make room for omission errors, where you want to do things, but you just forget. So having identified all of these problems, I would approach people in the hospital and share with them my findings, and everyone appreciated it, but I was not making any progress in making any changes at the end user level. And parallelly, in my life, I was pursuing informatics education with a 10x10 course, and I started that just before the Delirium project. And eventually, in summer of 2015, I had started my master's in biomedical informatics. I really liked what I learned in 10x10 course in informatics, and I wanted to pursue that further. So that was going on in my life, and that is where I got to learn really cool concepts like good usability is a real thing, where the computer interface is such that it provides you with effective, efficient, and a satisfying experience for a specific user in a specific context. And that's the definition of good usability. And I think we all agree, and there is some literature to support this, that EHR usability is not the best, as when you compare that to maybe an iPhone or other consumer level plug-and-play devices. So I also learned about the science called project management, and being a vegetarian, the slide on the left side accurately summarizes my understanding of what a stakeholder meant to me before I started learning about the science. And I would hear all these words of engagement and deliverables and operations, and they would not mean much to me. I would kind of understand what they meant, but not really. When somebody asked me to go granular, I would probably not be able to explain that. And it started to make sense to me that maybe why I was not making headway in the Delirium project, and maybe a part of the problem why I was not able to do that effectively was because maybe I was not communicating my ideas effectively to the team members. This coupled with my lack of prior leadership experience and the fact that healthcare is so diverse in the people, in terms of people who work in the healthcare setups and what kind of training and work backgrounds they come from. They all seem to speak these different work languages, and people in IT and informatics speak the data and the computer language. and people in quality and administration speak the language of project management and often use terminologies that are related to regulatory requirements, etc., which I was beginning to learn and understand as a part of my higher education. So at school, in my project management course, I pitched the idea of Delirium project for a term paper because this was not a usual setup where you have one organization and you have full control over what you're wanting to do, or at least there's no discrepancy or a difference in priorities. And the idea appealed to my classmates, and we got together as a team and started to work on this project for our term paper. And this slide on the first page, it defines the two deliverables that this project would fulfill, and one of them was to design a clinical decision support tool for the delirium patients to find them and to be able to treat them. And then there was also the revision of the order set, which was cause of unhappiness amongst physicians. So next we identified all the stakeholders in this project, right from the sponsor to the end user teams, and this helped us understand the responsibility matrix, meaning what is to be expected and what level of participation is to be expected from these people who are involved. As you can see, there is the Kaiser Director of Quality, there is Chief Medical Officer on SCL side, there is an external agency which is in charge of approving and redesigning order sets, and so on and so forth. And my role was sixth from the top, and that was hospital medicine, physician champion, and then with this stakeholder list, we started to define other elements of the project. And this slide is a little bit crowded, and I apologize for that. We performed a work breakdown structure for the Delirium project, and what that essentially means is you have your deliverables, the things that you plan to have in place as solutions to the problem that you're trying to solve. And those deliverables further need to be broken down into subtasks, and each one of them does not exceed 80 hours to accomplish, and it does not take less than 8 hours to accomplish. So that is the criteria for a task being a subtask. Otherwise, this list can become super exhaustive. So we broke down every major task, like revising the order set, into subtasks, and for example, if we look at the first one from the top, revising the Delirium order set, what all does it involve? It involves interviewing people to understand why the current order set is not working, reviewing the current evidence, rewriting a new order set, and then again getting feedback on the revised order set from all the stakeholders. You really want to measure twice and cut once in such situations, because it's a waste of everybody's time if what you've built is not going to be used. And then eventually submit the new order set that has been approved by everybody to the order set management group. And similar things for task number 3 and 4 and 5. And you plot that on, again, I'm sorry, the resolution on this slide is not great. This is a Gantt chart, and you plot the work breakdown structure on a graph, and on one axis you have the tasks that need to be done, and on the other axis you have a timeline of how long these are going to take. And what it does is identify the critical path for the project, meaning it'll light up all the reds in a way that if you were to move a certain task around, you would then result in exceeding your timelines for deliverables. And this helps a lot in planning tasks, also in a non-linear fashion. You don't have to finish one to be able to do the other. You can start them simultaneously, but the deadline for something can give you some sort of a buffer space. And last but not the least, project communication plan about how everyone involved will be notified and what will be the medium of communication and how often you're going to communicate with them. And as I was working on this project, another thing happened. The position for medical director of informatics opened up at SCL Good Samaritan Hospital, and I applied for it, and I was offered the position. And as a part of that role, I got to participate in various committees and advisory councils, one of them being Order Set Management Group, where I had wanted to represent this work that we had done until that time, and I eventually did that. And it helped me at that time to have understood the local organizational problems that were existent in this project. And I also presented this information to the group that the strongest evidence in this matter existed. The strongest evidence in delirium literature existed on the non-pharmacological interventions, and that it was not even a part of the order set that we had. And in my experience, I think critical pieces of patient management like these, where there is just overwhelming evidence to support a certain thing, should not get lost in such battles of whose responsibility it is. In fact, I think we should somehow design a win-win solution where it's easy for the right thing to do should be the easiest thing to do. And it's somewhat similar to maybe observing contact isolation in a C. diff patient, or performing hourly neuro checks in a patient who is admitted to the ICU with an acute head bleed. And all those are non-medicine orders, non-pharmacological orders, but we still put them in because we appreciate how useful they are. And I think this non-pharmacological intervention in delirium has the strongest backing by literature that it works. And at the same time, as a hospitalist, I was aware of how painful it was to click 10 boxes to implement these measures. And or when you have to order a medication like olanzapine separately, that was not a part of the order set. And so after brainstorming with other site CI leads and the CMIO and the clinical informatics specialists and architects, this is what came through. This is a screenshot of the revised delirium order set. The red arrows point to the changes that were made to the previous order set, and we specified non-pharmacological preventive interventions as a single discrete pre-checked order, which the physician would order, and this would automatically be this would transfer to the nursing side and as an actual order, and they would not need to look at any folder to be able to know what to do with these patients. And this solves the problem of a provider having to click 10 boxes. Also, the addition of olanzapine towards the bottom of the slide as a schedule and PRN option solves our second reason for dissatisfaction with the previous order set. But it still doesn't solve this problem where sometimes you want to order it, but you forget it. And it happens more often than you would like to acknowledge. And this is something that I learned in school with good usability and design and those things that I learned in human-computer interaction. They advocate reducing the cognitive burden on the end user with innovative solutions. And we were able to write clinical decision support rules in EPIC to automatically nest these non-pharmacological delirium prevention orders into any admission order set for all the high-risk patients who are more than 65-year-old, and they're coming from the ER into the hospital. So I really appreciated the effort that our informatics team at SCL put into this piece happening, because not only does this reduce the cognitive burden on providers. I mean, imagine having to, remember to manually put in all these. It's a big deal in terms of volume, but also the other great thing about nesting these interventions automatically is that you start these measures right at the time when the patient is entering the hospital. And again, the strongest evidence in delirium exists in preventing it. And you really want to focus your energies on preventing delirium, because once delirium sets in, and you all know this, that you're doing damage control and you take what you get. So this is a list of frequently used admission order sets at Good Samaritan Hospital. And delirium prevention measures are currently being nested in all of them as of July 2016. And it was very gratifying and exciting to see that what really started out as a project, a Kaiser project at a specific hospital, is currently benefiting all the 9 SCL hospitals and hopefully bettering the care for inpatient geriatric population and raising awareness on the management of delirium. And this has been a great learning experience, and I think the things that will follow from here is to share my experience with others and learn from their experience, just like we're doing it right now with the community of interest. We're also wanting to pull some metrics and measure things like length of stay, cost per case, use of psych meds, restraints in these patients, what happened to the associate injuries, what happened to the readmission rates, hospital-acquired complications, all those things. And the other thing that became more and more evident to me as I was working on this project is that associate education and change management and organizational readiness for a change is an often overlooked area. And that's where most of the things fall through, where projects really start with great enthusiasm behind the scenes. And unfortunately, you don't get the same engagement and energy at the end user level when it finally hits them. And partly, I think this is because of suboptimal change management techniques and using traditional education methods like, read and sign or handing out a test or something like that, which really is not how we are learning now as human beings. If I were to want to hang a picture on a wall, I'll probably YouTube it. And probably that is the direction we need to head in when you quickly want to deliver a message in a non-conventional way. And hopefully this project on associate education, which I have started to champion, will go in that direction. So looking back at the lessons that I've learned on this project, and hopefully they will be of some help to you guys, is that I guess one of the things that we should all do when we start on projects is to understand the problem from all different workflows. And I think I can speak for myself. I think initially when I started out, I would look at it only from a hospital medicine standpoint. And I quickly realized that it was so much more than just a hospital medicine workflow. And I looked at the nursing workflow and how informatics process requests and how long it takes for them to process this, etc. So all this helped me define my solutions better before I went to a certain person and said that I have the solution for the problem. And using a methodical and organized approach like project management helps us avoid frustration. And I would be lying if I didn't acknowledge that I had my share of bad days working on this project. I'd find myself frustrated, especially when I had to come in on my days off, and very often I would attend meetings where I would find myself repeating the same information for different people. But at the end of the day, nothing would move despite doing all that. And I think the class in project management taught me to plan better and to break the work to different people who work with you, assign a realistic time expectations to those tasks, and to also perform tasks in not necessarily a linear order. And kind of documenting it, putting it on paper, putting your thoughts on paper, it really helped with turning this project around. And broadening skill set in your areas of interest is always a great thing to do. Learning it can never be bad. And for me, this was informatics. And in the past year and a half, as a part of my program, I've learned about quality in programming and data analysis, and all of which brings about a different perspective and dimension to my work as a hospitalist and both as a hospitalist and an informatician. And working with a team doesn't need any explanation. Often, I'm reminded of Atul Gawande's talk. He's a Harvard surgeon, and he says that physicians and providers were trained to be cowboys, and with the rapidly changing landscape of healthcare, we need to be able to work as a pit crew. So with that, I'd like to end my talk and open the floor to any questions you have. Thanks again.
Wow, Rajat, that was awesome. You knocked it out of the park. I'm blown away. I have so many questions. So with that, I think everyone else probably will as well. So let me just say a heartfelt thank you. You've done excellent work, and I'm sure there's going to be quite a few questions. Miley, you want to say any comments before we open it up?
I'll just echo your thanks, and also am really impressed in terms of how you showed all the project management and infrastructure and stakeholder management. I think a lot of times it's those kind of more soft areas that are really crucial to a program's or project success. So I'm glad that you were sharing some of your tips in regards to those areas.
Excellent. So with that, and then also one last comment, it really drove home for me the need for biomedical informatics early on in a project, and you kind of had the trifecta there with being the director of that group. So
right.
I wish we all could be there. So with that, open up for questions. I know we got a pretty good chunk of folks on the line, and I'd like to start with some questions.
Rajat, this is Serena Lowe from Hawaii.
Hi.
Can you tell me a little bit more about how you engage, when you said the associate level, I guess your colleagues, how did you engage them so that they'll be buying into what you're wanting to do? Because oftentimes, hospitalists are busy. They hit the ground running, they have X number of patients to see, and, they're putting out fires all day long. So how do you kind of tell them, this is going to make things easier for you when, in theory, it feels like it's going to make things more work for them?
So that's a great question, actually. One of the things that I spent the most time on was initially understanding the problem. And every month when I would give my boss for this project, Dan Johnson, I would give him a call, or we would discuss things on an email. For a few months, I was just telling him that I'm still listening to people, I'm still understanding what is going on, because, again, people were happy to speak with me, but getting time on their calendar was a big deal. And I guess persistence and wanting to understand what actually worked and what did not, by talking with different people. I must have spoken with many people. I would say, I don't even know the number. I spoke with palliative care. I spoke with the heavy users of the Delirium order set. I spoke with our hospitalist group, spoke with the one down at St. Joe's, spoke with Midtown Internal Medicine, which is the other hospitalist group, spoke with palliative care medicine, spoke with psychiatry, nurses, and some themes start to emerge when you speak with so many people. And I think I'm glad I kind of did that homework, because sometimes you you're biased as an interviewer to find the same finding that you want to find, and you think was the problem. So when I heard about people forgetting to order it, and I was thinking that is really a very common problem, isn't it? Where Google can actually suggest the names of people that I should maybe email when I'm emailing my classmates, and I often email all of them at once. It suggests those things. But when we use EHR, we don't have the same experience. And forgetting to use was one such element where I could have said, well, you just need to remember to use it. And when I proposed that to my CI team, and I showed them the human-computer interaction literature that existed on this, it got something rolling. And there are some really great guys who've been doing this for a very long time. And they said, oh, how about we nest it in this way, where you can just have one criteria? How about everybody more than 65 gets this non-pharmacological intervention nested? And such things I think they have a flow to them. And I'm sorry, I digress about your question about how did I get input from these people, but just basically talking over time, a lot of talking.
This is Tracy, and I just have more of a comment. Raj, this is really amazing and very impressive work, and I think that one of the the most beautiful pieces of it is that you've really made it easy for people to do the right thing. I mean, I think that this has never been an issue of doctors not caring about delirium or not wanting to do the right thing. It's just been hard to do it because of the cognitive burden of all of the different tasks that they have to do. So making it easy, I mean, taking a systems approach and making it easy to do the right thing, I mean, that's, if we could translate that into everything that we do, the world would be a better place. So thank you very much.
I completely agree with you, Tracy. Thanks for your comment.
This is Deborah Francis from Northern California, and I have a question to go along with the previous comment and question that has to do with how you engaged the nursing staff to do the non-pharmacologic measures. We've had interventions on our delirium order set for a long time, but it's been quite challenging to get the nurses to truly understand the importance of this delirium, say, protocol. And it is a multi-component approach, lots of different things that need to be done. So did you have champions that helped you with that, and the education, auditing? How do you ensure those measures get done?
That is an excellent question, Deborah. I have been struggling to answer that question all along, where, if there is, as a hospital medicine physician, I feel that we get assigned many things that nobody else wants to do. And I think for nursing, it is even worse. The patient ratio, the pay, the expectations, all of those things are real things in the nursing world. And what I started doing on the side was to talk to people about sitters assuming this role. And, a sitter currently at our hospital is a contracted agent who is from a security agency. So they really don't know a whole lot about what a sitter's responsibility is. And what we are hoping to do in the near future is to hire CNAs and train them into behavioral health techs, which basically you tell them, these are the things that are expected of you, and please, don't sit in a corner and look at your phone and be at a risk for, being strangled. You're like, you actually list out the responsibilities that the person is supposed to do, like feed the patient if they can't eat, prevent them from falling, and if something starts beeping, please turn it off or call the nurse, or call the family and ask them to bring in their hearing aids. because nurses realistically don't have that kind of time to do all these things.
Mm-hmm.
And that is where we're headed with this whole element of engagement, that there should, and CNAs are a pretty inexpensive solution to this really expensive problem. Of $10 an hour, $15 an hour is not too much to be invested in these patients, and to have a steady stream of behavioral health techs is what we will strive for in the near future.
Very good.
Great, excellent question. Excellent response. Rajat, can you tell me a little bit more about the nesting of the non-farm measures and the order sets that aren't the general admin order sets? Can you just talk about that for a minute? I know it's a little technical, but there are a few folks on this call that I'd like to have hear that with Northern Cal.
What specifically do you want me to touch upon, Clay?
So when you say non-farm orders are nested into the other order sets, can you just walk through how that is? It's automatically cascaded in for folks greater than 65?
Yeah, it's a clinical decision support tool in the background. You just write rules, and I'm not a programmer, but I understand this can be done. So clinical architects are able to write rules inside the electronic health record. For example, we have Epic, and if we have a smoker who comes in, and in the emergency room, the social history is reviewed, and the smoking history shows up as a current active smoker, the Epic background is able to automatically nest the nicotine replacement therapy within the order set. So it'll know that the patient is a current smoker. It'll present to you the option of prescribing nicotine replacement. It'll even tell you at that point of care, at that point of decision making, how much this patient smokes, and what should be the recommended nicotine replacement dosing for that. So all these provisions exist within the Epic platform, and we started exploring them, and we use that for other things now.
Okay, that's great. And Michelle, I'm kind of telepathically connecting with you here. Do you have any comments for Raj on that topic or any other topics at the top?
Oh, you're funny. This is a great presentation. I think it's really helping us here in Northern California as we're putting together some very simple, similar things. So thank you so much. We're definitely going to take some of the things you've learned and put those in place for Northern Cal.
Thank you, Michelle.
Thanks, Michelle.
Clay, when Rob said, this is Serena Lowe again.
Hey, Serena.
About nesting, is that the same thing as what we have best practice alert equivalent? Is that what that is? When we nest it?
That's why I wanted to bring that up, because it's definitely different, and it helps avoid the BPA fatigue. So, Rajat, could you talk a little bit more about how nesting and cascading is different than BPAs?
BPAs are I think, standalone windows which, alert you of something that has not been done within the time frame that it needs to be done, as opposed to nesting is something that happens preemptively. For example, if you were to admit a patient, and if you have not put in a status order on that patient, which is necessary for triaging patients and getting reimbursements and all those things. So if you haven't done that and you're trying to admit that patient to the hospital, a BPA will fire and say, this patient needs a status order. And as opposed to nesting is something that for this particular project, or for nicotine replacement project, is something that happens within a commonly used element in patient care, thus reducing alert fatigue, meaning every single patient who is admitted by hospital medicine or orthopedics or surgery will need an order set. What is the diet? Do you need an IV? Do you need a DVD prophylaxis? So you will always use an alert, an admission order set. So these don't need to be BPAs. They can be nested within the admission order sets, and thus, preventing BPAs. Does that make sense?
Yes, but I'm just wondering, I'm not a hospitalist, so I don't really admit people, but I can imagine when we look at an order set, and if there's a lot of lines, a lot of things, and it's already pre-checked, would that be something that it would be easily overlooked, that you just kind of bypass it because you see it so often?
Sure, and you really don't want to do that with high-risk procedures. You really want to do that only with, things that have very minimum or no contraindication. And in case of delirium, I think this is a case in point. There is no reason for a patient not to be given their hearing aids, or to not follow a day-night cycle, or to be disturbed during night if there is no emergencies. And such things can work to your advantage. But, I wouldn't advocate pre-checking Coumadin or DVD prophylaxis or anything like that. That would need to be carefully and consciously chosen.
Great, thank you. That's very helpful. Serena, did that help?
Yeah, I think so. I'm just trying to figure out, what do you use, Clay? Do you guys use BPAs, or do you guys use nesting?
So we're currently kind of redoing how we're our order sets. So that's why I brought Michelle on, because Michelle and I are part of a work group that's, I believe, going to move toward that. I think we were calling it cascading, but cascading or nesting and that decision support, so it can be done automatically. So we're still redoing this. Right now we have the general order set that the doc has to remember to order, which is why I really liked what he was saying in the presentation, that unless it's automatically triggered, it's often not consistently done. So I'm advocating that we go toward nesting or cascading here.
Thanks.
So, Clay, do you? I'm sorry, Clay. Do you have? How do you? Do you have a best practice alert then for delirium, high-risk patients for delirium?
Not in Northern Cal. If anyone from the Southern Cal group's on the line, if you guys want to talk about your workflows, and I think Southern Cal has an active BPA turned on. Anyone from Southern Cal that wants to speak? Joria, I see you're on there, and I haven't talked to you in a while, so maybe you could chat for a second.
Hi, yes. I know there is a BPA, but I'm unfortunately not part of that pilot, but I think I saw others on, Lorraine Wu and some others. I'm sorry, I can't really answer that question.
No worries. I hope you're doing well.
Thank you.
And Kamal, maybe Kamal would know. Let's see here. I know the BPAs are down in different regions. That's part of the reason why these calls are so cool, because even though we all have kind of similar interests on how to treat delirium, our different regions have things set up differently within the backside of Health Connect or Epic.
Yeah, and there was one thing that what I was learning in school is I didn't want the whole process of providing this preventive care for delirium to come across as either obstructive or fatiguing by placing hard stops or BPAs. I think it can only get you so much. There can only be so many hard stops and so many BPAs, and I think there are examples in literature of CPOE systems just being crushed under physician rebellion because it was not letting them do their job, and it was overdoing it. And that is one thing that I consciously did not want to do in this project, because that would be the third failure then.
And Roger, I would like to say as well, in the country, not within our groups, I'd like to see what our percentages are, but in the country, delirium is coded only about 3% of the time. That's from Sharon Inouye's Delirium in Overweight People paper that came out in 2013. And anything we can do to automate delirium onto the problem list would be very important. So as you continue on in your role, I'd say I'd advocate for ways to automatically populate delirium up on the problem list, and that when people come back in, we've got history of delirium now in Northern Cal. So then we have our ER doctors and our frontline providers that have a heads up that watch out. This is a sweet little grandmother, but look what happened last time. So the more we can give each other bumpers, the better,
Yes, I completely agree. I think diagnosis codes are so notorious to be inaccurate that they're almost useless.
So while we got about 6 minutes left, and this is exactly the type of discussion we were hoping for. Other comments and questions? I see some folks on here I might try to pick on. Let's see. Any other questions? Kelly? No? Quiet. Miley, any comments?
No, nothing from me.
All right. Well, maybe I'll be nice and not pick on a few folks on here. Unless there's any other questions, maybe we could just do a little wrap up, Miley, and then let people off a couple minutes early.
Yeah, that sounds good. So just a couple things. After today's call, I'll send out the recording, and the slides will include a link to the Delirium Wiki that has a lot of great resources and that we continue to add to as we see good things. And then we will have our next call in November.
Awesome. Well, again, thank you very much. This has been a really great call, and I've got lots of tips and tricks I can use now. So thanks again, Rajav. Really appreciate your time.
Thank you. And I want to thank you, Clay. Initially, when I came on this project, you helped me really understand the whole project from Northern California standpoint, who was you were already doing it, and I was wanting to get the kind of support that you had with the nurse practitioner, but we faced a roadblock in that sense in staffing. But you really helped me understand how you guys were doing it, and that was the fun part of it, where I could collaborate whenever I wanted with you. And thank you for being so responsive.
So it's our pleasure, and we look forward to learning more from each other. And again, thank you for your time today. That was really great.
Thank you.
Great. Thanks, everybody.
Thank you.
Thank you very much.
Bye-bye.
Bye.